Welcome to the Vinci Trebuchet presentation, Burden Reduction and Overview for Providers. This content was presented during the March 13th, 2025 biweekly Vinci Trebuchet public meeting. Scott Rossignol, Solution Architect with eHealth Exchange, and Karen Ashton, Director of Population Health Digital Solutions with MultiCare Connected Care, provide an overview of the Vinci Burden Reduction Implementation Guides with insight into a provider organization's implementation experience. This presentation and all Vinci presentations are offered under the HL7 antitrust policy to ensure appropriate collaboration and information sharing.
Welcome, everybody. I wore my best flannel for you today. Here to talk with Karen about burden reduction and some of the experiences that MultiCare has had, as well as some of the experiences we've had at the eHealth Exchange surrounding the implementation and other just overall conversations about getting a use case into place. Karen, did you want to introduce yourself quickly before we get started?
Thanks, Scott. I think Michelle did a great job, and so I'm happy to be here to chat with you. And for those that don't know MultiCare Health System, MultiCare Connected Care is our ACO arm. We're in the Pacific Northwest. We have 13 hospitals and over 300 clinical sites. So that's a little bit about our organization, and I'm happy to be here to share what we did in burden reduction.
Great. So jumping in, I think what we're going to do is start off with a quick overview of burden reduction, CDEX, and also talk a little bit about TEFCA and networking for connectivity, since that's such a core topic to everything that we're doing at production scale. Then we're going to delve into three key topics that healthcare providers need to really dive into themselves and understand before they're going to be successful with burden reduction workflows and implementation. We're going to talk in depth about what it means to tackle these topics and what you really need to be thinking about, and rolled up these holistically really bring you the picture of what it means to roll out a burden reduction or electronic prior authorization solution. We'll be calling out some key decision points and some next steps along the way as well. So hoping that folks can get some actionable insights out of this discussion, as well as some learnings from the trenches here. Okay, so wanted to start off by just summarizing what burden reduction looks like from the provider's perspective at a high level. Right, so burden reduction is electronic prior authorization, and this is really in a point-to-point scenario where the provider and the payer are communicating. I haven't indicated any networking here. I wanted to show a very simple approach. But you have that provider submitting the CRD query, the coverage requirements query, to the payer. And as a result, essentially the payer is going to indicate whether prior auth is required. What are the next steps, if there are any? So as a result of number two, a lot of providers for a lot of requests are actually seeing no PA required. Nothing more you need to do. So that can be a very quick process, and that's one of the benefits of this solution. But in the case that there is a prior authorization required, we move on to step three, which is requesting that DTR questionnaire, populating that DTR questionnaire, saving that questionnaire back to the electronic health record, and finally submitting the prior authorization with that DTR response, the questionnaire response, to the payer. In some circumstances, one of the reasons I wanted to highlight this process is that the payer might need additional data, in which case, at this point in time, around step 6.5 here, we introduce the CDEX attachments workflow for additional data. In the case of a CDEX attachments workflow, where the payer needs additional data, they're going to submit a FHIR query back to the provider. This query can take a number of forms. I haven't gotten into depth on those, but what's important is that the payer is initiating a query to the provider as part of this process. And that's actually different than every other part of the flows, where the provider is initiating the queries to the payer in electronic prior authorization. And so I'm calling that out because at the technical level, that actually requires separate setup, and it requires separate thinking from the provider standpoint. This is really core to getting prior authorization working. You might not be able to do a lot of prior authorization without the CDEX attachments flow. And so it's actually something kind of this sidecar that expands and expands in scope as you actually start looking at it and understanding what it means. So we'll talk about more about that detail in the coming slides. But finally, to get back to the flow here, we have step 7, where we're actually going to get a prior authorization outcome back into the EHR or the Smart on Fire application. I didn't mention that before. The provider side can really do this process in using a couple of methods. First is EHR native workflows, and I'm very supportive of EHR native workflows because those are going to be the best thing for the providers. But EHRs don't support this today. You can't do a native workflow in the EHR today in any EHR unless you're in maybe Epic's Connectathon environment, right? So nothing in production allows for EHR native electronic prior authorization workflows today. So in the absence of those, we have Smart on Fire applications. Those applications can do this today. They are doing it today. They're doing it in production, which Karen's going to tell us a little bit about her application experience. I'll let you all read through some of this slide, but these are high-level details around the process. I'm sure most folks are familiar already. We are constraining our fire queries into the US CDI APIs. Providers have the ability to manage their workflows in a few ways, which is also important. The providers have primarily the goal of electronic prior authorization is to put that workflow into the exam room between the provider and patient so that that provider can see that result immediately upon signing the order. But that's not necessarily what providers are going to choose to do initially. So they have options in workflow. They can do different things within their electronic health record or within the user processes to actually perform prior auth. Because there's flexibility there, there's some differentiation in how the payer might need to support that flexibility. And there's some decision making that the provider has to do to understand what is the best approach for them. There's also a really core topic that I want to make sure everyone's aware of and thinking about themselves. How do providers only expose the right data to the payer? Now, I'm not saying that providers need to only provide very, very specific note to the payer as part of this process, right? Like we're trying to get rid of that process with electronic prior authorization. We're trying to democratize data and make more data available to both parties. But there is still sensitive data in the electronic health record that cannot go to that payer legally. In those cases, the provider really needs to think about how to set up their processes and the data exchange, both with prior auth and with CDEX, so that that data is protected. All right, I'm going to talk a little bit about TEFCA. I'm not a TEFCA expert. I work a lot in the field, so hopefully I got all this right. But TEFCA is, the concept of a national network, enabling connectivity between participants. So that means that payers, public health, vendors, health systems, anybody on that network is able to communicate and share data using the TEFCA SOPs. One thing about TEFCA is that they define mandatory SOPs. Mandatory SOPs means anybody participating in that use case, healthcare operations or treatment, must respond to requests. That doesn't exist in the world today of prior authorization and electronic transmission of data between payers and providers. There's no like really mandatory electronic methods to ensure that data is accessible for either party. So that mandatory nature of the process is really one of the most important parts to the national network when it comes to the availability of data and the availability of connectivity on the network. The availability for a provider to actually send an electronic prior authorization to a payer or a payer to be able to get CDEX data back out from the provider. That mandatory nature is really crucial, or else people will just say, no, I'm going to close off my APIs, which is sort of the default that we see in the industry today. TEFCA is live today. It's only live for treatment and individual access purposes, broadly speaking. It's not live for healthcare operations. It's not live with fire. It's not really live with payment use case either. So those are barriers to using TEFCA right now for what we're talking about. In the future, we see healthcare operations and payment use cases, prior authorization, CDEX processes becoming mandatory in TEFCA. We want that. I think everyone on the call, if you're not aligned with that, I would love to understand why. But generally, what that means is it gives us a national network with mandatory responses, allowing us to tap into that network and connect to the partners that we need to trade data with. That's really crucial, and that I wanted to kind of highlight that. Thinking about pilots in Trebuchet and pilots in general, or the work that you're doing, a lot of that work is point to point. It's between you and a trading partner. Maybe there's a vendor in between as well. So maybe you have 3 or 4 parties in the mix total, but it's all kind of in this line, right? It's all point to point. TEFCA enables the network connectivity, which means that there's a central hub or several central hubs in the concept of a QN, and everyone connects into that hub, which means that you have connectivity to every node in the network with a single connection to the hub. Connectivity is really crucial in this process. If a provider wants to submit prior authorizations to all the payers that they work with, they need to be connected to all of those payers. My point on this slide is that connectivity is much easier in a networked environment like TEFCA compared to a point-to-point environment where you might have a new patient come in with a new payer that you've never seen before and you need to connect to. So just wanted to highlight that problem exists and there is a solution to that problem available. That solution is TEFCA. That solution is immature. We need to work together to mature it. Join a cohort if you want to work on that. All right, so in summary, of our overview here, the burden reduction and CDEX process enable that streamlined or fully automated prior authorization process. TEFCA enables connectivity, and combined, these enable happiness. These allow for providers and payers to communicate, to do so in a standardized manner, and to allow payment and operations to flow via FHIR over the networks. Okay. I think at this point, it's time for Karen to speak a little bit about the operational challenges that come alongside burden reduction implementation.
Thank you, Scott. I'd like to take a couple of minutes just to give a little background on how we got started and just to set the context. And from what Scott just presented, we're doing the Smart on FHIR concept, the application in point-to-point. That's what we've put in production. And as a organization, we're now working on a TEFCA-like model with a network FHIR through the Trebuchet group. So that's our 2 use cases, one that we have in production and one that we're in the middle of piloting now. And just to let you know how we got started, because I think this will explain some of the operational challenges that you see on this slide. And these are just questions for you to keep in mind as you're planning your own pilots and how do you get adoption, how do you onboard your stakeholders and move forward with it. We had dabbled already in FHIR in doing quality measures with our partner Cambia Regions back in 2019. And we had started with DEQM use case, then went into ATR and membership and rosters in 2020. And by 2021, there was the idea of let's do this prior authorization. And so we started there. And one of the big things we had to get in place was contracts. Some of those are trading partner contracts. At the time, because everything was done X12, we had to do a waiver. And so we worked on that. And so when Regions came to us and said, hey, with their partner, MCG, and said, we'd like to do the Smart on FHIR app, we thought, all right, let's figure out our why. So one of my guidance is always to figure out what your why is in doing this. And I think it's an easy one for healthcare providers in that it's really all about the patient. So we went to our revenue cycle group to get the stakeholders in place and talk to them a little bit about, can we sit down and understand how you do your work today? So one of the first things we did was sat down and did a workflow diagram with our prior authorization teams. And personally, from my perspective, I'm an IT girl, and not having been in that workflow before, the more I watched the boxes and the lines pointing here and the time frames it took to do things, really realized it was such a tedious process. And while portals are great and other things are great, we could find ways to improve this for our stakeholders. And really who wins in the end is the patient, because this is done better, faster, and quicker. So that activity really reinforced our why. So after we got our stakeholders involved, we determined, here's our why. We outlined the guiding principles so that we could work with our partner. Because one of the great parts about the relationship we have with Cambia and this particular Smart on Fire app was that we got to sit with them and help design the user interface. And as Scott already mentioned, there's other apps out there today. Our process was a little bit longer, but there's other apps out there today. And my hope would be that this process would be simpler for you, because I love when I can just download an app and do some configuration and have it ready and available. So that's where I think that's where we are and we're heading. And that's why I hope this journey would be a little quicker for you. So once we defined, like I said, the stakeholders, the why, we outlined the guiding principles. We wanted to reduce clicks, reduce the determination time, have the app launch right in the workflow so they didn't have to leave, and of course try and reduce paper as much as we could. And when you sell that to your stakeholders, they're ready, willing, and able to step up and provide some time with you. And if you think about the timeline I outlined as well, that was during a time where a lot of us went working from home and dealing with financial crisis in the healthcare industry. So it really became an area where we wanted to see how we could do things better and quicker. So that was really what prompted us to do that. And so as I think about some of the other areas, adoption was key. We decided that we'd figure out a way to measure this so that we could show the return on investment, because when you show that, then you get further adoption. So I'm going to share a couple of slides in a moment that really show how we promoted our adoption. Education, training is a key area that we looked at as well. I think we had good materials, great materials actually, and really it was a matter of having them available and having our teams just adopt and try it out. I think that some other areas that I wanted to just highlight was test cases. So one of the things we had to do along the way was determine and set up in our systems, how do we test this? So that took a little bit of time for us to test and develop. But as I said before, once the app was built and we were ready to use it, it really was, let's bring the app in, let's configure it, and let's get going on the prior auths to this particular case. So as I said, there's been lots of advancements. Scott's already highlighted that there's apps out there today. And, as you bring them in, I think the key things to think about is the adoption, the stakeholder engagement, any kind of security reviews that you need to go through in your organization, and really from a Smart on Fire app perspective, install the app. And so I'm going to flip, Scott, if you move to the next slide, please. About what I want to highlight here is, as I mentioned, we went live in October of 2022. We made a decision that we really wanted to do all three IGs. So we wanted to do the CRD, DTR, and PAS side of it. We had other tools in place. So we really wanted to measure the big picture ROI, which is why this was, a use case that we wanted to be part of. And at about the 6-month mark, our authorization team conducted a time study. And it used to take them about they could complete 3 to 5 prior auths in an hour. And after using the app, after the app was installed and they were using it, they were up to about 10 to 12 per hour. And as I stated before, patient is at the point, is the center of what we do. And this productivity allows PAs to happen faster, so the patients in our world their treatment faster. I pause for just a second on, you'll see other types of tools listed here. And so we know we're going to have multiple solutions at MultiCare. We have the Epic Payer platform in place and have a couple of payers that we're connected to that way. But so we'll always know that we'll have these tools as well to have. So it really becomes a decision on what's available, what can be done, and the regulations are coming along. So some of these things will change, obviously, in the very near term. And I think the other thing I wanted to highlight on this page too is that the app that we have in place now, for those of out there that are on Epic and may have what we call a Community Connect program, we're able to also extend this application to our Connect partners, once they sign the trading partner agreements with their payer partners out there. So the Smart on Fire app that we do with Cambia was built so that we could have that ability to install it on our Epic platform and to be able to make it available to specific service areas, as they call on the Epic side. So I know folks ask about what other types of solutions we have, but that's just wanted to share that component of how the app works within our native environment. And then, so the next slide really highlights that 10 to 12 auths that we can do in an hour is reducing our burden. And it's a 233% increase in our team's productivity, which is great. They've come to call this button. Do you want to flip to the next slide, Scott? Thank you. Our teams have called this what they call the magic button these days. And, they love it. They can work through it faster and get the patient results back. And these are our productivity results. And as I said, the patients do get in sooner. And at the time we did our study, Regents also looked, and I want to just share a little of those stats with you. They looked at our sample of the authorizations that came through and found that 41% of them were auto-approved. And then another 60% determined that there was no PA required, as Scott just mentioned earlier. And so we were informed almost immediately then. And that process, looking back at our original workflow we went through for a no PA required, that took 3 to 5 days to process and find out. And we were getting that within seconds. So again, patient at the center, that means our patients get seen quicker. So just want to make sure that we talk a little bit about not only the numbers that you see here on the screen, but there's also a qualitative benefits that the clinical data sharing that happens in this three-step process is really focused on the minimum necessary, which I like. And our groups get to see that data and determine if something has to be removed or added on to, if, for example, some of the policies aren't built in for certain types of procedures. The other benefit that came out of this for us was the collaboration with our partners. And we have a direct line to Cambia if there was any issues or challenges with this. And in between these meetings, we have in between, we have meetings that we also still get together with and talk about what enhancements can happen. And one of the key optimizations we've done since we originally implemented this was getting the approval and denial letter back in the EHR so we have that readily available if we need it for the future. And then we're continuing as an organization. We're not a dev shop at MultiCare where we have limited IT resources, but this allows the folks that love this work to stay connected and be up to date on the requirements. And of course, as we all know, while this supports the patient and timely care, it also is supporting the regulations that are out there. So I'm going to pass it back to Scott to talk a little bit more about the technical challenges. And then I'll kind of highlight one other area when he is done. Thank you.
Thanks, Karen. We will have time for questions at the end. So if folks want to drop questions into the chat as they're thinking about them, we can address those. All right. So the technical challenges here, I kind of got into detail on the slide because technical details are, the only way to communicate them is one way, and that's through detail, right? So the challenges that we see with prior authorization implementation are around the support of the workflow. What technology will you use to actually enable the workflow in your EHR? The connectivity to the payer. How will I actually send and receive requests from the payer? And then the connectivity back with CDEX. There are also challenges around sensitive data that we're going to discuss in a separate the legal and compliance topic. And I actually want to take a step back and talk about a challenge that comes before any of these, and that is to figure out who in your organization actually owns these processes. So Karen, if I could put you on the spot for a moment, with MultiCare, how did you identify the right leader in the organization to work with to say, hey, I want to institute electronic prior authorization. We want to give you a magic button. How do I get in front of your users and get this, so I can communicate the change, that I can validate the workflow, that I can get feedback after we go live in production? And how did you get approval to put this magic button in place?
The process of prior authorization is somewhat centralized at MultiCare. So we went to our revenue cycle leadership, and when you think revenue cycle, we're always looking for ways to save money, and the timing of when this all happened, shared with them what this technology could do and how we could bring it into the EHR. So we basically partnered. I mean, it was promoted because we'd already been doing some work with Vinci, the Vinci project, and we'd shared some of those wins that we had with the DEQM and with ATR, and so said this is what we could achieve with prior authorization. So when you have good partnerships inside your organization and you can tell a story and then determine how you're going to prove that story, that was the leadership that supported us and gave us some folks who were really dedicated to making this happen. So we just had some strong support on our side.
Great. So you were able to find the right people relatively easily, and you were able to get decision making by a leader. In other pilots that I've been working on, I just want to highlight that provider organizations actually have a hard time finding the right people. And so that's one thing as a provider organization or somebody who works with providers that you have to think about in advance of any actual implementation work. It's who's the decision maker and how do I get in front of them? Sometimes the provider office hires a person for prior authorization, and that person isn't actually reporting upstream to revenue cycle leadership at the health system, right? So there are some different things to consider here about how do I get in front of the right people? How do I make decisions? Is it just an Epic IT decision or an EHR IT decision, or is there more to it than that? Do I have to go to my HIM department? Do I have to go elsewhere? Really understanding what the approach is here to have decisions made is the first step in this process, the operational, steps that you need to take that Karen had mentioned. So I don't want to spend a lot of time on the technical challenges. I think I already kind of gave you the spiel earlier about EHR support, about connectivity, why TEFCA is valuable, the national network concept. And really what I suggest here is if there's a way for providers to start thinking about piloting this on a limited basis, to learn about it and understand it before you really push it out, that's going to be a very valuable a way to obtain that information about how your EHR supports things, about how you want to do prior authorization, which payers in your area are actually able to provide you the endpoints needed to do this work. Going out and learning all those details now is not going to make your job in the future harder, right? It's going to get you that groundwork. So I certainly recommend that folks start thinking about that and start laying the groundwork today as far as identifying the right folks, getting conversations together, starting to educate people and really bring the conversation forward so that when you're ready to do the technical implementation, that you're able to get that started relatively easily. All right, jumping forward, Karen, I think we had this slide for you here.
Yeah, I wanted to include this slide, just really highlight, and most folks out there might be shaking their head, yes, identity is key. And so it's foundational to care, to know who your patient, your member, the provider, the location is. And so I wanted to highlight this because we did have some challenges along the way when we were implementing the Smart on Fire app. Patient merge issues happened because, patients, we keep all the active coverages in. So a patient might have a primary and a secondary. And if we merge those patients together, then, we might pick, we pick what's in our EHR, but then when we're matching up to the provider side, the payer side, sorry, then they may not match the same way. So we had to deal with those challenges. We had out-of-date plans in our EMR. So one of the things on the provider side is really look at your foundational systems. And if you can master, the first thing we mastered was the members, and we're trying to master patients inside our EHR as well. And we're looking at provider and location now because they're very key. So I just wanted to bring this one up to leave that thought that this is preparation you can do now for any of the use cases, really, whether it's HEDEX, prior auth, anything. And even with the current one we're doing now in the network fire, we've come across challenges with, NPIs and providers. So I think it's important that you keep this in your consideration when you're thinking about some of the technical challenges you may have.
Great. All right, so let's start off talking about legal contracting and policy as sort of a four-step process, if you will. That four-step process is really, sorry about that, all right, about that educational component that I mentioned. We want you to get started working on these topics before you get started working on the technical pieces. That is the takeaway that you can take from this call. That's a good one. We want you to understand what it is people need to know in your organization, start getting them up to speed, and bring together the right information so that folks can really understand what value they're getting. Why is this going to be a positive ROI for the revenue cycle team? That's what we're trying to help you with here. We're bringing some of those numbers to you and also some of these lessons learned. So first, understanding TEFCA and ROI and policy. A lot of provider organizations are used to national networks today. They do this for treatment. But provider organizations are also used to not giving payers a lot of access to their database. They're not saying, hey, payer, you can query whatever you want and have all this information, right? There are certain safeguards in place from that perspective that are going to change with TEFCA. And I commented on this earlier. I said, we want to be able to allow payers certain access unfettered to their members. And we want to be able to rely on law like HIPAA to say that payer's not going to go get a bunch of data that they don't have the right to under HIPAA. That's what trust is, and that's what TEFCA, that's the T in TEFCA, right? So it's not just about understanding that TEFCA is a national network, that it gives you connectivity. That's simple. But where is the ROI in this process for a provider organization? The ROI could be in provider access APIs. Can you go get data from a payer that you've never had before and that you could really use for certain purposes? Maybe it's in member attribution. Maybe you're spending a heck of a lot of time right now as a provider managing payer rosters. If you could standardize member attribution in a way that allows your team to spend 90% less time ingesting rosters, then there's an ROI there. And doing so at scale, across connections, across payers, is really the goal, taking us from step 1 in this slide to step 4, which is looking at defining and projecting a go-forward approach in payer contracting processes. So I think Michael Westover could tell you, and Karen could tell you, and a lot of other organizations that have done this work can say that the payer contracting process between payers and providers is what's going to drive how you work together in the future. So ensuring that the folks that are working on those contracts understand your goals and your needs at a technical level. I need this pair to be on TEFCA. I need this pair to be fire enabled for these purposes. That allows you to set up a goal that you're moving towards in the future. Let's say that's your next contracting process, that you're going to get these installed in. And then finally down the line, you're going to say, okay, well, come this year is when we're going to require this capability in this contract. That allows you all to work towards these goals together, not to mention that they're mandated by CMS, but it gives you the option to really set a concrete date and move towards that in your business world and in technical world. Today, with pilots, with Da Vinci burden reduction, that doesn't really exist. Right now, it's a lot of folks saying, this could be great. I could get a lot of value out of this. Karen and MultiCare said that I could get a lot of value on it. So there's evidence, but we don't have the structured go forward approach. And that's what I'm suggesting here on this slide, is that you can get to a structured go forward approach through your payer contracting. And in order to get to that payer contracting endpoint, you need to do those first 3 steps. You need to understand why you're going to get value out of TEFCA, why you should be signing this agreement to potentially mandate you to expose more data. Why are you going to request payers to integrate, and how are you going to request payers to integrate? We've got a lot of great presentations on that through this Trebuchet group that you can look back on as well. And then the last piece is that protection of sensitive data, which I'm going to talk about on the next 2 slides. Hoping that makes sense. Let's go ahead and jump forward here. So sensitive data, this will be our last topic. I think we've only got a couple more slides after these 2. So with sensitive data, there's a few topics to consider. Self-pay encounters is the first one. If a patient decides that they want to self-pay and they specifically opt out of sharing data with the payer, that means that legally, under HIPAA, the provider should not share that data with the payer. There are some other carve-outs. I'm not telling you the law here. I'm kind of trying to point you in the right direction though. But those self-pay encounters aren't necessarily tagged in your EHR. You know that in the EHR, you know that this encounter is self-paid. You don't know that patient opted out of sharing necessarily though. Is there a flag? It doesn't usually exist. So understanding when and if you can share the encounter data for a patient means that you might have to do some work in your EHR, or you might have to do some work outside of it. And we'll talk about like some of those concepts on the next slide. Now, these other topics are really more concrete. It's not as though you sometimes share data that is, you don't sometimes share psychotherapy notes. You don't sometimes share women's health data, even if your state law prevents it, or HIV results, because these are pretty hard and fast. Do not share this information with the payer organization. And so in these circumstances, you really do have to look at each type of data and understand how it's exposed in your system and how it might be exposed in the future. Psychotherapy notes might be part of a behavioral health department. Maybe every appointment in that behavioral health department in an Epic system is under break the glass. So by not allowing that user access to break the glass encounters, you might be able to restrict psychotherapy notes inherently. Maybe there's more to it than that though. Substance use disorder documentation, 42 CFR Part 2. Again, how is that protected? Is it in your EHR? These are things that we really need to understand as providers before we start working towards any solutions. What is the baseline here? Finally, with state law, understanding what your state's laws protect, understanding how you're protecting that data today, because it is being protected. It's not going out on CDA documents necessarily. And understanding how FHIR works with that data are all going to be core to restricting access to it. So if anyone, I kind of already gave you an action item. If you take another thing away from this presentation, it's going out and figuring out what your sensitive data is in your system. This is a good starting point. I've done this research for you all, so please use it. But what else is there, and how is it protected? How is it exposed via FHIR? Can I make a FHIR query to your observation endpoint and get an HIV result back? Like if so, then you might actually be exposing it today. These are things that we need to consider and make sure of as you're thinking about payer integrations and really setting your system up for the future. not so that you could set up a single integration moving forward, but so that every integration moving forward is compliant. With sensitive data, there are kind of 4 ways to think about this. These are broader buckets. What I've done is organize them into less effective versus the most effective, and less difficult versus most difficult. Unfortunately, the least effective solutions are the easiest to implement. The most difficult ones are the hardest. That's not always the case, but it seems to be here. Starting off, thinking about your FHIR queries themselves, if a payer only requests lab results using LOINC codes, and those LOINC codes don't include the HIV result type, then you can be sure that that payer is not receiving HIV results, right? So that's a very easy way to ensure certain access by requiring that the payer only uses specific FHIR queries and query parameters. Using EHR functionalities is the second tier, that break the glass concept that I just mentioned. So having your EHR set up in the proper ways to restrict confidential encounters, to allow users, to disallow users access to that data or APIs access to that data based on that confidentiality could be another option for you to protect some of this data. I think the last two are really the longer term approaches that we think a lot of organizations are going to take as they see the scope of the issue, or, maybe not. I don't have a crystal ball, but the use of a vendor is something that's pretty common today, where an organization is actually pushing data to a vendor, and that vendor is exposing the data to payers. You can continue with that process. You can be compliant with, a lot of the CMS 57 requirements as a provider by allowing a vendor to serve your data to those requesters and not doing that yourself. That's not going to work for prior authorization data, though, because prior authorization requests come out of your EHR, uses your EHR data directly. And sometimes it's using data that's not even filed yet, like a pen or an order that is about to be signed. So does that vendor work for that use case? It's one of those nuances that we need to think about as we're deploying. Finally, standing up that separate FHIR API layer. Now, this is what MultiCare did. They have their environment where they have data that is taken from their Epic environment, and I think other EHR environments, and plopped into a separate location. They have FHIR APIs enabled into that separate location, which gives them full control over how data is retrieved, how data is accessed, and all of that outside of what their EHR vendor has provided. So that separate FHIR API layer, that separate data repository is a decent option. Again, though, it doesn't really work for prior authorization data because it's not in real time. It's not available from the EHR. So there's nuance to this. There's nuance to how you're sharing data, to what use cases and workflows you're sharing data in. And you're only really going to understand those nuances while you practice. You have to go do the thing in order to really understand how this is going to work. All right, I did promise that I was done. If you want to get involved with additional conversations and learn a little bit more from us, please join these calls. We love having new folks join. Bring your entire team, bring your family. And then finally, that pilot cohort sign-up sheet it's just so sad. It's empty. I need more pilot cohort representatives. So please, everybody, if you are interested in piloting your software, get in contact, sign up. It's not, I'm not going to make you sign in blood. You can back out if you're not able to this quarter, if there's something else that goes on. But what we want to do is create this community and create momentum moving forward to get those pilots running and to see success and more lessons learned like this. Thank you. That's our spiel. What questions do we have?
Ellen has a question in the chat. Are you able to use SQL at all?
CQL is a valid tool for certain purposes. The EHRs don't really support CQL today for many purposes. The smart apps could do CQL for your DTR processes, but it's not really an effective tool for all of the sensitive data management that we had talked about.
And Scott has a comment in the chat as well. My understanding is that payer participation in TEFCA has been minimal to this point. Have you encountered any common payer objections to joining? And if so, do you have any suggestions for overcoming those objections?
I think we're all sort of standing around looking to see who's going to do it. I think there are objections. One objection I've heard around TEFCA that is significant is the ability to charge fees for healthcare operations. I think a way to work around that is for providers to simply state they will not charge fees for queries that you're working with payers on, right? I think as we get to a networked approach and we really hit scale where you're not communicating with every one of your trading partners on a regular basis, that becomes a little more difficult. But for now, if we're talking about contracting processes anyway for payers and providers to agree upon a data trading standard, why don't you go ahead and insert in that contract that you will not charge fees for healthcare operations, and that would overcome that challenge. I think we're not at, I think that we have a chicken and egg problem right now that we will overcome with TEFCA. The chicken and egg problem is simply that not everything's live yet. We don't have SOPs for certain really critical use cases. I've already talked about those on this call. So as these things come about, as we see maturity, we're going to see a rush of folks coming in.
Thanks. There's a question about, can you clarify how CDEX document exchange works in terms of burden reduction?
Yeah. So really quickly, it is a FHIR query from the payer to the provider. What that means is that the payer must establish connectivity with that provider. If you're in a point-to-point environment and not inside of a trust community like TEFCA, that means that you're setting up a FHIR app on the provider side to access their data. If you're using an organization like eHealth Exchange, you can get access a little bit faster. TEFCA is sort of the next level where you'd actually be able to get access in a dynamic manner to any new participant.
Next question is, what is the biggest roadblock to the adoption of the burden reduction IGs? Isn't it supposed to be good for both providers and payers?
Karen, I want you to take
Yes. I think sometimes it's just getting used to a new tool in some cases, because it's good for both providers and patients providers and payers, but ultimately it's our patient and our member that we're serving. And the more we can do to reduce the time to get prior authorization done, the better for that patient. So we owe it to them to do this together. And I think this is what this community is about. And I need to go sign up for a cohort. Sorry, Scott. And that's what we're here to do together. Yes, technology always is thinking.
Mike Gould also posted that sensitive data includes orders, meds, diagnoses, chief complaints, problem lists, and more. So I guess just a comment on that.
And to say that shouldn't be a reason to stop. It's something that we have to filter so that we can respect the state laws and individuals' needs as well as HIPAA. But there are plenty of use case scenarios that we can put into pilots that can steer around those kinds of things, particularly if we're using simulated data.
Thanks, Mike. Emma has a question not related to your work, but if you have time, can you briefly summarize the bot technology mentioned on the slide related to PA transactions?
Yeah, it was actually a tool that we were using and we're no longer using, that would just, let the bots do their magic and look around to see if they can get out there. But we've since retired that. But if you...
Right. Yeah, I think we're at time. If folks do have follow-up questions, we're happy to, help via email or anything else.
Yes.
Thank you all for joining us. Thank you, Karen and Scott. And please, everyone, join us for our next meeting on March 27th.